Welcome back, everyone. I'm still waiting for Roberto, so let me introduce myself. I'm Justin Wu from Hong Kong. So this session is Physiologic Investigation for Gastroesophageal Reflux Disease, and we have the pleasure to have 4 distinguished speakers in this session. So Roberto is coming. Yeah, so without further ado, I would like to introduce the first speaker, and Daniel Sifrim. His talk is on normal thresholds for reflux episodes, the international normative study. Thank you.
Hello, good morning, everybody. Like everybody else, I would like to thank the organizers for inviting me to participate in this meeting. I want to make 2 comments before I start. The first is that this is going to be a slightly boring presentation on values and normal numbers and things like that. Forgive me for that, but sometimes these numbers are necessary. And the second is a kind of feeling that I started performing impedance studies in more than 20 years ago, and we came up with normal values 2 years ago. And this is a shaming, because we spent like 20 years without having the real normal values that we can use all over the world. Having said that, at least I am proud that I have them now, and I would like to share this with you. So these are my conflict of interest. So what I will present today is a summary of the normal values and regional differences in esophageal pH impedance metrics that was a very long-lasting collaborative study that include all that list of people from all over the world that very generously shared with us the little number of studies performed in healthy asymptomatic subjects. So most of the studies before this included 20, 30, 40 healthy asymptomatic subjects from one country. And I had the idea that there is probably a regional difference in several parameters of reflux monitoring, and probably also differences due to different systems used to measure things. So we decided to collect a very large number of studies to deal with this problem. We received 541 impedance tracings from supposed to be normal asymptomatic subjects. And we had to eliminate 150 of them. Why? Because they had a confounding diagnosis, either because the patient marked reflux symptoms, and they were, if they had symptoms, they were not a normal asymptomatic studies, or they were reporting that they were taking reflux medications, or in the HRM there was a large hiatus hernia, or we were concerned about the possibility of having eosinophilic esophagitis because in their baseline impedance was low all over the tracing. So we needed to eliminate 86 of this in that way. And then there were artifacts in the tracings, either technical in pH or impedance artifacts, software artifacts, short recordings, or wrong pH sensor positioning, either too low or too high. So the result is that we ended up with 390 healthy subject tracings that we considered clean and appropriate. They were mainly performed by 2 different systems. Diversatec, at that time was Sandhill, and now is Diversatec, and 126 from the Labori tracings. And there was an initial meeting at the Wingate Institute in London where a group of experts came to discuss in a consensus way, the way to analyze these impedance tracings. and that included Frank Serbip and Sabine Roman and Eduardo Savarino, Prakash Jawali, myself, and Eduardo Frazzoni as well, Marcio Frazzoni as well. So we discussed over the weekend the criteria to identify reflux episodes in the impedance tracings visually. I'm not going to discuss now the PSPW because this is going to be discussed later by Nicola, but I would go through the criteria that we use to make sure that these are reflux episodes identified manually. The first thing was to correct the meal periods. We had the impression that in many tracings, meal periods were not correctly marked by the patient, and we needed to edit the duration of the meal periods based on the impedance pattern. You have a very typical impedance pattern during the meal, and we were able to use the impedance pattern and the gastric pH increase due to the meal to make sure that the meal periods were right. For us, a reflux episode was defined by a 50% drop in impedance lasting at least 4 seconds in the 2 distal impedance channels with a retrograde propagation. An important issue is that a pH drop below 4 concurrent with a 4 seconds 50% impedance drop following a belch was considered as a reflux episode, belch-related reflux episode. Another important thing that was a pH drop without impedance detected reflux episode was counted as part of the acid exposure time, if not an artifact, and was not considered a separate reflux episode if it was not detected by impedance. This is a matter of discussion, by the way, but this is the way we did it. And finally, the way we did it was that we run the automatic analysis software, and then we edited the tracing, either adding missed events or deleting those that were detected by the automatic software, and we considered that were not reflux based on our definition. Okay. The first thing we looked at was the relationship between the values and gender and age. And what we found was that males had significantly higher total acid exposure, higher number of reflux episodes, and lower MNBI at 3 centimeters above the LAS. Within the normal values, the males had more. There was no significant impact or linear correlation between age and levels of total acid exposure in normal subjects. And finally, older subjects had lower MNBI in the distal esophagus. And this is something that we confirmed afterwards, and we are now, at this moment, working on that topic to know what should be considered a normal value for an 80-year-old patient that is coming to get an impedance study. Concerning total acid exposure, showed that there was a significant difference in the way that Diversatec and Labori techniques measure the total acid exposure. And I must say that I still do not understand why. We deleted those pH drops that we considered that were either within the meals or outside the meals. We edited all the pH drops for all the studies, both the Diversatec and the Labori. And still the Labori gave a much higher acid exposure time than the Diversatec. And I think that it has to do with the software and the way the two systems are calculating the total acid exposure, the software, and I don't know how it works, but there is clear differences. In any case, the 95 percentile was 2.8 for the Sandhill and 5 for the Labori. So the values in healthy subjects, 95 percentile, are below 6 as the Lyon consensus considered. However, this 2.8% in 250 normal subjects, to me, is very important. If you have a patient that has 4.5, as it was discussed today, in my mind, this is not normal because of this data. When we look at the number of reflux episodes, again, there was an important system and regional variability. However, the 95 percentile for the Diversatec was around 50, 55. So in those people that are using Diversatec, a cutoff value of 50 as a normal value of number of reflux episodes is more adequate than the 73 that we were using until now. Not for those that are using Labori systems where the number of reflux episodes was higher. And this is the topic that I am more interested in, that is the mean nocturnal baseline impedance. We analyzed this and we found that the 5 percentile in normal subjects was around 1,500 rather than 2,200 as it was proposed by the Italian group and is until now considered the cutoff value. So for us, even with the two systems, the cutoff value should be around 1,500. Those subjects that have less than 1,500 in the distal esophagus have an abnormal mucosa, but those subjects that had 1,800, 1,900, 2,000, they have a normal mucosa. Concerning the PSPW index, which is also considered by the Italian group with a cutoff of 60%, meaning that healthy subjects have a 60% PSPW index. This is not what we found in the 390 healthy subjects. There are a lot of normal subjects with much less than 60%. To give you an idea, the 5 percentile in some cases was 15 or 20% in healthy subjects. So this topic of PSPW needs to be reassessed in the concept based on what we found in normal subjects. And there were important regional differences. For example, if you use the same system, Diversatec, and you look at the total acid exposure, you will see that in Latin America, in yellow, the 95 percentile was 5.3%, whereas in the Asia and in Western Europe and the US, it was significantly lower, around 2.7, 3%. So there are regional differences that cannot be secondary to different systems. We now looked at same system in different countries. And as I said, the measurements with the Labori system were much higher than what we saw with the Diversatec. Not only the acid exposure showed differences in regions, but also the number of reflux episodes detected. And again, the Labori system used in Asia, in the Netherlands, in Turkey, and South Africa showed higher number of reflux episodes. I repeat that these studies were analyzed using a consensus criteria by the same people during half of the pandemic period with Skype analysis. We were the four of us sitting there, sharing the tracing and discussing each tracing one by one. Interestingly, there were also regional differences in the MNBI, and I am not surprised at all. You can see that there are, independent of the system that you use, there are countries where the 5 percentile is lower than in others, particularly in the subjects that were studied with laboratory testing, and you can see that the 5 percentile in Turkey was 1,200, whereas in Asia was around 1,900. So there are differences in the baseline impedance, and I said that I'm not surprised because I strongly believe that the same way that there are skin differences, there are mucosal differences, normal mucosal differences in normal subjects. So I'm not surprised that there are differences in this. And another thing that I wanted to comment is something that Sarah Board mentioned on the first day, yesterday. The same way that we found differences in the MNBI measured with impedance pHmetry, it's very possible that the mucosal integrity measured with other techniques also have regional differences. So I wouldn't be surprised that if you use the mucosal integrity with the balloon or with the new cup system, there will be regional differences. So there are, as I said, differences in the places where the patients were studied with the same technique, and also in the Diversatec or in the laboratory. So I would like to conclude with the following. This is a short, boring presentation, but I would insist with the practical implications of this. We report findings from the largest collection of impedance pH studies performed in healthy asymptomatic subjects obtained from multiple countries and 5 continents. The most relevant parameters reported are the new thresholds for esophageal acid exposure to define physiological reflux depending on the system that you are using. There are significant system-related and regional differences in most reflux parameters reported for impedance pH monitoring, making it important for each center and motility lab to use normative data relevant to their world region and impedance system used. And finally, these new normal thresholds are to be used only if careful editing of the impedance pH tracings is undertaken. These are not working in the just automatic analysis, push and report. So the last reflection I want to make is that in spite of important amount of comments made during these first 2 days in this meeting about the importance of doing everything at the endoscopy room, or about the relative need of performing reflux monitoring, or even about the differences between catheter-based or wireless pHmetry, there is still a lot of people doing catheter-based impedance pHmetry in the world. And I think that you should consider the possibility that the normative values are very important depending where you're living and the equipment that you are using. Thank you very much.
Thanks very much, Daniel. I must say that your talk is not that boring, so I believe there would be some interesting questions. So, John? Hold on a second. The mic is coming.
So the question between the systems being 2.8% and 5%, there's an easy way to figure that out. You download the raw data into an Excel spreadsheet, and you look at the differences, and you do that manually. We did that when we noticed that the Bravo capsule and the slimline catheter-based catheter were recording different values. And when we went back and looked at it and we downloaded, we could clearly see that there was a difference. But in retrospect, it was the thermal correction, the thermal calibration equation that was actually wrong on the catheter-based slimline that needed to be corrected. And that was easily figured out by taking the catheter and dumping it into orange juice, cranberry juice, and looking at the differences in pH that would be recorded. So I do think that is shocking, 2.8 versus 5%. And I do think that these data need to be downloaded manually into an Excel spreadsheet to first discern if that difference is real, and then someone needs to look at those thermal calculations that are occurring by doing simple orange juice, cranberry juice, water, and looking at that. And that's a simple way to figure that out.
Thank you. This is a very good suggestion. We will do it.
So, thank you. So, obviously, that's a technical point and very important, but I have a clinical question. So, these are normal values, and clearly, we understand in functional diagnostics of all kinds that there's a large overlap in many situations between what we might regard as normal and what we see in patients and what we see that is truly pathological. So there is obviously a concern about this 2.85%, but above what level do we consider true pathology to be present? Do you, Daniel, think that this is more to do with symptoms, or should we define this independently related to the presence of erosions on endoscopy or some other independent factor? And is that not actually the threshold that we're looking for if we're trying to make clinical decisions as valuable as the normal data is? How do we use this in clinical practice?
In my mind, in those patients that have a low acid exposure, I am wondering whether there is a relationship between their symptoms and reflux episodes. Regardless of the algorithm that you use, and regardless if you are using both SI and SAP together or one or the other, my concern is whether the majority of symptoms were preceded by reflux episodes. And for that, there are two things that needs to be done. First, you need to delete the multiple symptoms bottom pushing that happens, and if you are not editing the tracing, there are many more symptoms than the true, let's say. First stupid thing, it takes 30 seconds. And then you need to be sure that the reflux episodes are reflux episodes. So once you have these two things done, then you are able to know whether the symptoms of the patient are time-related to reflux episodes, and you can call that hypersensitivity or not. But in my mind, to me, it's still a very important factor to know whether the symptoms are reflux-related or not.
Thank you. In the interest of time, we need to move on. I understand Serbo has got another question, maybe during the lunch break.
There is one.
Right,
Just quickly to expound on what John said about calibration. What we did that really told the story was to do a concurrent recording with both systems on the same patient. And there's just a consistent offset of so much one pH unit will do everything that you showed.
Yes, we discussed that possibility, and we were planning to do it, but it's not easy to get healthy volunteers to swallow the two catheters. We think this is actually, this is what we wanted to do, but the proposal of John is also very useful. Maybe we need to do both.
Okay. Daniel, thank you. Thank you very much for your fantastic talk. You said boring, but it was very, very useful and great work. Now we have a video presentation, isn't it, Mark? Yes, from Radu Tutuian. And the subject of the talk is TLESRs and other causes.
Well,
do numbers
everyone.
and types
It's
of
a
reflux
pleasure to be
episodes
here with
matter?
Sorry, he couldn't wait for you to stop.
you, even though virtually. And what I would like to do this morning is to address two questions, and those are if the number and the types of reflux episodes matter in the pathogenesis and investigation for reflux disease. Now, investigating reflux, we usually take patients with symptoms suggestive of reflux disease, and you are all familiar with the esophageal or the extra-esophageal symptoms that bring patients to our clinics. In terms of clinical investigations, PPI trials have been used and are currently used by primary care physicians. We often perform upper GI endoscopies, grading findings according to the essential classification in class A through D. And in terms of physiological testing, what we heavily rely upon is reflux monitoring, and here we can use either capsule pH monitoring for most prolonged studies, or impedance pH monitoring if we want to look at characteristics of reflux episodes and or understand the pathogenesis of symptoms on PPI therapy. We can also use high-resolution manometry or esophageal pressure topography, sometimes combined with impedance, in order to see if there are additional factors contributing to the pathogenesis of GERD. And I'm not sure how many of you use this in the clinical practice, but there are some good evidence on the use of mucosal impedance for investigating GERD. Now, the latest AGA clinical practice update for the evidence of GERD puts together the data from upper GI endoscopy and for prolonged reflux monitoring of PPI therapy, and affirmatively defines GERD by the presence of LA classes B, C, or D, or the presence of abnormal esophageal exposure time defined as percent time pH less than 4 of more than 6% in at least 2 days. It also excludes GERD in patients who have no erosions on the upper GI endoscopy, and the esophageal exposure time on all days using prolonged pH monitoring is less than 4%. This now leaves the area of esophagitis Los Angeles A with either normal esophageal exposure or abnormal exposure in one of the 2 days, as well as patients with normal with non-erosive disease but abnormal exposure time on one of the 2 days, as the groups of borderline evidence for GERD, in which the other characteristics of reflux episodes might help to provide answers to reflux. These clinical updates are based largely on the Lyon consensus that was published 5 years ago, in which beside endoscopy and esophageal exposure time, we defined several adjunctive or supportive evidence for the presence of reflux in patients complaining with previously mentioned symptoms. For this talk, I will now focus mainly on the reflux characteristics and see what evidence they have. We have to see if they matter or not. Again, to this audience, there is no need to explain the principles of pH monitoring, but would like just to mention that if we use the capsule endoscopy, we have now the opportunity to have prolonged esophageal exposure monitoring at a fixed position above the Z line. And the impedance pH monitoring, which offers us the opportunity to characterize the reflux episodes identified by impedance according to their acid content into acid, weakly acidic, or weakly alkaline, or if you want to prefer to use the term of non-acid reflux. Beside acid characteristics, impedance offers also the opportunity to look at the characteristics of reflux episodes in terms of content, and we can distinguish pure liquid reflux episodes if we see only a drop in impedance, then pure gas reflux episodes on the far right if we have only increases in impedance during these events, or the mixed types when we have the mixture between drops and increases in impedance, as shown in the middle example. For reflux episodes. In addition to the composition, we can also determine the height of the reflux column and the duration of bolus presence time in the esophagus. And these are factors that can help, and I will show you the evidence on how they do in determining the development of reflux symptoms. Among the first studies was that published by Adrian's group back in 2006, where they looked at the factors which influence reflux perception of PPI therapy. What they found in this study was that symptomatic reflux episodes compared to asymptomatic reflux episodes had a lower nadir pH, had a higher pH drop, and more often going all the way up to 15 centimeters compared to the asymptomatic reflux episodes, which had higher nadir pH, had a lower drop in pH, and did not reach that high into the esophagus. These results were to some extent confirmed by Michele Cecala's group in Rome, who also analyzed the characteristics or the factors associated with reflux perception of PPI therapy. And here he found that in patients with non-erosive reflux disease and in patients with erosive reflux disease, episodes with an acidic content were more likely to be associated with symptoms compared to weakly acidic reflux episodes, and that mixed reflux episodes, these are these gas-liquid reflux episodes, were again more likely to be symptomatic compared to liquid-only reflux episodes. Now, as impedance pH monitoring can also study reflux on PPI therapy, several groups looked at the reflux perception on PPI therapy. Now, Frank published also in 2008 a analysis of the factors that make reflux episodes being symptomatic on PPI therapy. And here, among all categories that he looked at, found that only the proximal extent of reflux episodes was different in symptomatic and asymptomatic reflux episodes. The other characteristics such as nadir pH, bolus clearance, bolus burden, and so on, in his group there were no differences. We, on the other hand, we also analyzed the characteristics of symptomatic and asymptomatic reflux episodes in patients who were referred or investigated on PPI therapy. And among the factors that we analyzed, we identified that esophageal extent, meaning the higher they got, the more likely they were symptomatic, and the composition, that means mixed reflux episodes were more likely to be symptomatic compared to liquid-only reflux episodes, although we have to admit that the odds ratio here are rather on the discrete, on the 1.3 to 1.5 side. A recent study published by Arian's group together with Andres Maut at the AMC looked now at factors that determine reflux-induced chronic cough of PPI therapy. What they found here was that mainly the proximal extent was different, but equally volume clearance, then the reflux burden as the volume presence time, that these were all important factors in causing a reflux episode to induce cough. So briefly summarized, we have evidence for both typical and atypical symptoms on and off PPI therapy that proximally extend to a certain degree volume clearance, reflux burden, and the mixed composition are all determinants of symptoms. Now, how about the number of reflux episodes? Is that important or not? Here, this is a study published by a group of surgeons where they looked at when they compared the laparoscopic sphincter augmentation, the magnetic band, versus double dose PPI in managing patients with moderate to severe regurgitation as the main symptoms for GERD. And these are data from a randomized controlled trial. As you know from this study, regurgitation was relieved much better with the magnetic sphincter augmentation compared to PPI BID in terms of relief of regurgitation, relief of GERD-related quality of life symptoms, and overall satisfaction with the reflux condition in patients who were suffering from moderate to severe regurgitation. And what the study also shows is that the patients following magnetic sphincter augmentation had no regurgitation, the vast majority of them, almost 80%, whereas on doubling PPI dose, 90% of the patients were still having moderate to severe regurgitation. Now, beside this data on the sphincter augmentation for controlling regurgitation, is maybe this post hoc analysis performed by Prakash and Marcello, using the data that I just shown you, but now they looked at they wanted to see if they can find characteristics of reflux episodes that would help improve the regurgitation. Again, this is a large study including 152 patients that were referred for either double dose PPI or magnetic sphincter augmentation for persistent moderate to severe regurgitation on standard dose PPI. And these patients were evaluated 6 and 12 months after randomization. A group of the PPI allocated treatments were allowed to switch over to magnetic sphincter augmentation after 6 months. What they looked at improvement in the foregut symptom questionnaire, especially on the regurgitation score. They defined symptom responders, those who had at least 50% improvement in GERD quality of life, and patients who were overall satisfied with the therapy. So this was their definition of symptom responders. Now again, maybe present a different way. The percentage of patients with regurgitation, with persistent regurgitation, was higher in the patients who were receiving PPI BID compared to the patients who were having who underwent magnetic sphincter augmentation. And the GERD-related quality of life scores improved more in patients undergoing the magnetic sphincter augmentation compared to PPI therapy when it came down to regurgitation. And then in this post hoc analysis, they compared the group of patients who responded and those who did not respond, to what extent these patients reached a normalization of the number of reflux episodes, defined as less than 40 reflux episodes over 24 hours, as defined by the Lyon consensus. And here they found that in the responders group there was a higher proportion of patients who had less than 40 reflux episodes compared to the group of non-responders, where the vast majority of these patients had 40 or more reflux episodes following either magnetic sphincter augmentation or double dose PPI. Also, they performed an ROC analysis using this data to identify the optimal number of reflux episodes below which treatments need to reduce the number of reflux episodes in order to get a resolution of symptoms. Here we're talking mainly about regurgitation. And they found that for satisfaction with therapy and for GERD-related quality of life, 35 reflux episodes over 24 hours appear to be the optimal threshold for symptom improvement. And they also found that a increased number of reflux episodes, meaning more than 80 reflux episodes on standard dose PPI therapy, predicted satisfaction with GERD management after magnetic sphincter augmentation, suggesting that the number of reflux episodes on impedance pH monitoring has clinical value in evaluation of GERD and assessment of GERD treatment outcome, in particular when it comes down to regurgitation. Some conclusion, ladies and gentlemen. Do numbers and types of reflux episodes matter? I hope I could convince you that yes, they matter. These are really now recent data showing that the number of reflux episodes is an important predictor for regurgitation, and that an increased number of reflux episodes as well as a reduction of number of reflux episodes into the normal range help improve one of the major symptoms of reflux disease, namely regurgitation, and that characteristics of the reflux episodes such as proximal extent, volume clearance, mixed content are important factors in causing reflux episodes to be symptomatic. Whether these characteristics really matter or not will need to be answered by studies addressing the question whether changing or reducing the proximal extent, reducing volume clearance, or eliminating the gas out of reflux episodes can really contribute to the symptom control, in particular now in this group of patients who have borderline evidence of reflux disease. These are these patients with Los Angeles class A and maybe abnormal acid exposure in one but not all days of PPI therapy. Thank you very much for your attention, and now I'll be open for question on a live session. Thank you.
Thank you. Thank you very much, Radu, for your very interesting presentation. Hi. Now, any comments? One or two very quick.
So obviously you may have to relay questions in both directions. Radu, I'm not quite sure on the quality of sound.
Yes. Hello, Radu.
Oh, sorry, it's maybe mute.
Hi.
Mute already.
Mute.
No. Say something, Radu.
Radu? Oh, good. Okay, we hear you. Okay, anyone wants to comment on Radu? What do you think, Justin? About, I think it's quite just you remind us of a very important data that were shown that in fact symptomatic episodes are in relationship to nadir pH, to the change of pH, and to the proximal extent, which is quite important. In fact, tells us why some of the reflux episodes are perceived and some not. So this is really important information with us. And now I was just wondering whether some of the patients with regurgitation operated on were ruminators or not, but probably doesn't matter. I mean, they stop anyway. Do you know whether they were excluded or not?
As far as I know, they excluded patients with rumination based on their symptoms. I think that the surgeons were careful not to include those patients based on the clinically available data.
Okay, okay. Well, if there are no questions, all right, just one quick question there. Right?
Hello, Radu. Jan speaking.
Hello.
Hi. Do you have any disclosures to make concerning magnetic sphincter augmentation, or do you think it's we should stop giving PPIs, or did I miss something in your talk?
Well, no, I think for this group of patients, which are the ones that have severe regurgitation, I think that PPI alone will not function. Now, we know data on the baclofen as add-on therapy, and we know the New England VA study, which shows that the response rate in that group is probably about 30%. And I think the magnetic sphincter augmentation study really shows that in these patients, you need to have a barrier method to improve it. And I think it's one of the first studies which shows that one of these parameters which we may be tended to neglect, saying, well, we focus on the acid exposure time on the other parameters, but a number of reflux episodes may be actually giving us important information in selecting the patients who would benefit from a sphincter augmentation procedure, be it magnetic, be it operation. I think it's really the first one that shows that, well, one of these studies really has an outcome data. And I really have to commend Prakash's group for reanalyzing this data with that specific question, not only going on the outcome of the difference in the methods, but really looking behind the data on what can be extracted in terms of information from these patients, and really see who benefits from this kind of therapy. I think in that regard, the analysis really gives us really hope and encourages us to keep looking for this reflux episode, saying that we need high number in order for recommending patients to undergo sphincter correcting procedures.
Peter, you have a question there? Yeah, we can.
Yeah. So, hi, Radu. This is Ronnie Foss.
Hi, Ronnie.
Hi. So, you focused on symptom perception on peripheral factors. I think we're missing here, and we should not underestimate central factors that determine symptom perception. And we have a pretty extensive data about that. And not only that, altering those central factors can improve symptoms. So when it comes to symptom perception, it's the combination of peripheral and central factors.
All right, thank you very much. I couldn't agree more with you on that. I mean, it's really the expectation and all the let's say supraesophageal factors that played a very important role. And I think you have shown us over and over again how important these factors are in doing that. For this talk, I really focused just on the peripheral. It was sort of looking at reflux episodes and really trying to see on the peripheral mechanisms. But you're absolutely right. These patients equally benefit from central therapies and the way that they perceive, the way that they report, and the way that they approach this. Agree.
Well, I think honestly we should go on. We have 7 minutes late, and so we pass to the next speaker. Thank you very much, Radu, again.
Thank you. So our next speaker is Nicola de Bortoli, and his topic is novel impedance measurements contribution to GERD diagnosis.
Thank you, Mr. Chairman. Thank you, dear colleagues, and thank you, Mark, for his kind invitation. This is my disclosure, and okay, the novel impedance measurement that contribute to get the diagnosis can be summarized in baseline impedance calculated with different technique and the PSPW index. For baseline impedance, the first study came from Faré and from Kessing, and the first study showed that in vitro and in vivo study using transepithelial resistant and histological assessment of dilated intercellular species showed that baseline impedance in the distal esophagus is correlated with impaired mucosal integrity. And from the study of Kessing, we showed that patient with pathological acid exposure time had a lower value of baseline impedance, and that baseline impedance was inversely related to acid exposure time. There are different techniques to calculate baseline impedance. The first is MNBI, mean nocturnal baseline impedance, that is calculated during the night when the baseline is more stable, because we hypothesized that the esophagus collapse on the probe, and if we choose 3 different time window of 10 minutes, approximately around 1, 2, and 3 a.m., and excluding a moment in which there are swallow, reflux event, or pH drop, we can calculate the MNBI. Another technique is the manometry-derived baseline impedance that is very easy to be calculated because it also can be measured in conjunction with the high-resolution impedance manometry and can be measured during the resting pressure calculation. And then, more innovative, the direct mucosal impedance measurement. It is use a specific device that allows direct measurement of mucosal impedance, and that is able to eliminate potential artifact due to the contact of impedance channel with the mucosa. The other interesting technique is the calculation of post-reflux swallow-induced peristaltic wave index, well known as PSPW, that is calculated by dividing the number of reflux followed by 30 seconds, within 30 seconds, a swallow-induced peristaltic wave with the number of total reflux, and it may represent a measure of chemical clearance. And the impairment of chemical clearance is a primary pathophysiological mechanism in GERD, and it seems not change enough after medical or surgical treatment, and patients with erosive and non-erosive GERD seem to have lower value compared to healthy volunteer and functional airborne. How works these metrics? First of all, we analyzed a patient with not with GERD, but with the functional airborne that were classified as a functional airborne with the classical technique, and baseline impedance measurement might allow for the identification of patients who respond to PPI, but who were classified as having functional airborne. Another interesting study, this is the first study that enrolled only patients of PPI treatment, and all of them was responsive to PPI, large number 289, divided in patient with erosive GERD, non-erosive GERD, and control, and both PSPW and MNBI were able to differentiate patients with positive NERD and those with negative NERD. In this study, we compared and analyzed the MNBI and PSPW index in patients with the refractory, and the study was performed in a patient on PPI treatment, and enrolled patients with refractory erosive esophagitis, ileal erosive esophagitis, and NERD, and those were separated from functional airborne, both with the PSPW index and MNBI. In this study, we evaluated a large number of patients according to the Lyon consensus, and focused our attention on patients with inconclusive acid exposure time, and the metrics used total number of reflux, PSPW, and MNBI. Even the cutoff value are just be discussed by Daniel Sifrim and should be probably reviewed. But these metrics seems to better separate patients with GERD from those with no GERD. Even with the artificial intelligence, this study from the Washington, University of St. Louis, and from University of Padua applied the artificial intelligence for the calculation of baseline impedance during all the track. And the conclusion of the authors was that baseline impedance was extracted very easily from the software, and the recumbent AB artificial intelligence baseline impedance strongly correlate with MMBI at 5 centimeters from LES. Nothing to add regarding what Daniel Sifrim discussed regarding a normal value and regarding the differences among the different manufacturer and different regional, and as well regarding the Wingate consensus that put the attention on how to calculate reflux episode and how to calculate PSPW index. This is very nice that if this could be improved in future, we probably have the possibility to apply intelligence, artificial intelligence to our tracks and to improve the calculation even of this new impedance parameter. Advantages of MMBI and PSPW index that are catheter-based metrics. MMBI and PSPW index can be easily calculated with this existing technology. No additional costs are required, and technology is already available in most tertiary esophageal centers. Only catheter-based analysis allow the calculation of PSPW index and MMBI without adjunctive cost, and maybe improving the GERD diagnosis as the study that I show. Disadvantage that a group of patients is considered pH impedance monitoring uncomfortable, and all technique with catheter are considered uncomfortable for some patients. Then direct apposition of the catheter to the mucosa cannot be guaranteed, and the interpretation of MMBI require manual software manipulation, and PSPW index is considered time-consuming measuring, and so we have to discuss a lot about that. Regarding baseline impedance measured during high-resolution matometry, it is very easy to be calculated because it's required only 50 seconds during the landmark period of high-resolution impedance manometry. And in this study from Ravi was enrolled patient with GERD and control, and this matrix baseline impedance was able to separate well GERD from non-GERD. Similarly, the same study was proposed with water perfused high resolution manometry. The technique for the calculation of baseline impedance was quite similar, and the conclusion were that during the water perfusion high resolution manometry, it's possible to differentiate patients with GERD from those with no GERD, and there is some possible contribution as a potential utility in predicting PPI response in this group of patients. More recently, Amit Patel and Prakash Gyawali evaluated two different manufacturers and evaluated the baseline impedance during high-resolution impedance manometry with the Medtronic and with the Diversatec in setting of physiological seed exposure time. And they calculated the BI during the landmark period with 5 centimeter and 10 centimeter above the LES, and then correlate with the MNBI. Their conclusion was that there was a good correlation among baseline impedance calculated with the high-resolution impedance manometers with MMBI, and especially for the corresponding impedance channel. And they underlined that there were some numeric differences in baseline impedance calculated with the high-resolution impedance manometry between different manufacturers. Advantages. Manometry is performed more often than ambulatory pH impedance monitoring, and so we have a lot of patients that be calculated directly baseline impedance with this metric. and with this technique. High resolution seems very easy to be calculated, the baseline impedance with high resolution impedance manometry, and the calculation and the first data seems promising. Disadvantage is that few data are still available, and during high resolution impedance manometry, we do not allow any information regarding the classical GERD parameters, acid exposure time, number of reflux, and symptom reflex correlation. Some differences between manufacturers has been shown, and PSPW index cannot be calculated. Then, at the end, mucosal impedance, that is a new way to diagnose reflux. This technique is pioneered by Michael Vaezi and co-worker, and the device that is used through the scope allows the direct calculation of mucosal impedance in different parts, for example, of 5 centimeter and 2 centimeter from squamocolunar junction. And in this setting, it was able to separate patients with GERD, with erosive GERD, from those with the NERD and the abnormal pH, and those with the normal pH and the normal exposure time. A similar study was reproduced with a larger number of patients, and then including a patient with achalasia, and then with eosinophilic esophagitis. The results were very similar, and eosinophilic esophagitis showed a very low baseline impedance value, and where the technique was able to segregate patients with abnormal GERD, with GERD with abnormal pH exposure from those with the normal pH exposure from achalasia. And in patients with erosive esophagitis, the techniques was repeated after PPI treatment, and the baseline impedance, so the mucosal impedance, improved a lot after PPI treatment. This is the most recent and famous study because used the balloon, the esophageal balloon with the 2 strips longitudinally placed electrode, which measured the impedance, 9 impedance points per strip, and was performed from Vanderbilt and Rochester University for internal validation, and then in St. Louis and Chicago for external validation. They enrolled patients with GERD, erosive esophagitis, and abnormal prolonged wireless pH monitoring, patients with eosinophilic esophagitis defined with histological finding, and non-GERD. And the technique was very able to differentiate these 3 different characteristics according to mucosal impedance calculation, and the area under the curve were very promising. Advantages: direct measurement of mucosal impedance seems intriguing, especially with the new technique with the balloon catheter. And the acquisition and interpretation are easy and is very rapid. And this novel device is recently approved by FDA. Disadvantages are quite similar. We have few data regarding mucosal impedance till now, few studies. And it is approved only in the US and is not allow any information regarding the classical reflux-related parameter. Adjunctive cost for doing this technology, and PSPW index cannot be calculated. So I have to conclude saying that baseline impedance is an emerging technology that conceptually has developed over the past 2 decades and has entered as armamentarium or esophageal test. PSPW index is a different, intriguing metric. It seems workly very nice according with MMBI, but is considered too time-consuming. The greatest utility of baseline impedance at the present lie in the cases of reflux metric are inconclusive or borderline, especially acid exposure time, and baseline impedance seems able to efficiently segregate patients with GERD from patients with no GERD with the old technique. And more therapeutic outcome studies are needed because the currently available data has been performed with the MMBI. Thank you for your attention.
Thank you very much, Nicola. So we allow 1 to 2 short questions. Mark, do you have a question? Okay. John.
It was a very nice summary. A couple questions. You know, the idea that one single test, given the fact that the pathophysiology of GERD is so multifactorial, you know, we have people with a hypotensive LAS, hernia, significant acid exposure, people with clearance issues. I think it's really, we put too much pressure on these tests to predict these things in and of themselves as a sole test, because you know there will be people who will have normal clearance but will have significant clearance issues because of a hernia, you know, that will be missed at that. So I think it's important when we look at these area under the curves in these studies. You know, it's crazy to think that any of these things are going to be 90%, you know, as a single test. So I think we've got to get that out of our head. The one question I have though for you is, how do you differentiate, you know, in these, especially in impedance studies, whether this is truly an issue of mucosal permeability versus just liquid, you know, and poor clearance and reflux events, especially at night, because we know that, you know, the primary thing that'll drive the impedance down is going to be liquid. It'll be refluxate, saliva, you know. So how do you differentiate that? And do you think, I guess, these mucosal integrity products are having value and that you can be more consistent with that? And my declarations, I'm conflicted by everyone. I'm not Laborie yet, but I'm hoping this meeting.
No, I agree. I totally agree with your conclusion, with your. I totally agree because we put too much attention on baseline impedance, but it should be used only when the other technique, for example, acid exposure time and total number of reflux, are not conclusive. When we have patients with not enough evidence of GERD and no history of GERD, it could be only an adjunctive test for GERD. And so I think it should be only considered in a gray area, not more.
Is there any further question? If not, then thank you very much, Nicola. We need to move on.
Thank you.
And now we have Rena giving us the last talk, clinical and physiological assessment of extra-esophageal reflux symptoms. To you.
Thank you. So I also will be sharing some art in my presentation, but this artwork is actually from one of my patients that has had chronic throat clearing and voice hoarseness, and he feels that his life has completely been taken over by these symptoms and not having any answers. You know, this is a real problem. I think probably one of the most challenging entities that we all manage. So I'm hoping to go over where we are today in terms of clinical and physiologic assessment, but probably ask a lot of questions and hope to hear from all of you as well. So these are my declarations. So these patients that come in with throat symptoms, whether it's throat clearing, globus, and so forth, you know, we know that their journey is very challenging. In that first year, they will see multiple providers across the board, on average 10. They'll undergo multiple diagnostic tests. The literature says on average about 6. And at the end of the day, no matter who they're seeing or what their results are showing, about 80% are given a diagnosis of extra-esophageal reflux or LPR just based on their symptoms alone or maybe non-specific findings on laryngoscopy. Most of them will be trialed on PPI, but we know that there's about a 50% response. We'll talk about this a bit. There's a significant quality of life impairment. And in the US, it's estimated that all of this accounts for about $50 billion annually. Now, in terms of symptoms, extra-esophageal reflux symptoms are not specific, right? We know multiple other conditions can cause these symptoms either in a silo or in concert with reflux, and that includes voice conditions, pulmonary conditions, and so forth. And studies have shown that if you take patients that had a symptom-based diagnosis of LPR and they undergo ambulatory reflux monitoring, about 50 to 60% will not actually have abnormal reflux tests. So we are clearly over-diagnosing this condition. So how about PPIs? Well, it kind of depends on which study you look at. These are two relatively recent meta-analyses. The red boxes identify the studies that differ between the two. Basically, they both are saying the same thing, but one crosses the confidence interval of one doesn't. So basically, PPIs perform similarly to placebo in randomized controlled trials. Maybe they have a modestly better improvement than placebo. Tom Carroll and the Harvard group conducted this interesting cost minimization study a number of years ago, looking at, should we be starting with empiric PPIs or do upfront testing? So when they modeled it out in terms of starting with PPIs, on average, it was costing about $3,000 per patient. And then when they modeled it out in terms of starting with ambulatory reflux monitoring testing, it came out to about $1,900. So there was a cost-saving aspect if you start with upfront testing. And again, this is not about the dollars. Again, this is artwork. It's dark, but it's beautiful also. And these are some quotes that I've gathered along the years from patients that I see, and just all their social functioning domains are really tremendously impacted by these symptoms. So it's not the cost, it's not just on us and as the providers, but really in the patients. So we need to move away from diagnosing these patients based on symptoms or their response to PPIs, and we need to really adopt this upfront testing strategy. And fortunately, the field is moving in this direction. Most of the professional societies are aligned on this recommendation. But the challenge is what does upfront testing mean, right? This was the recent AGA best practice advisory that Joan Chen was the first author on. And they said there's no single diagnostic tool to diagnose LPR or extra-esophageal reflux. And we need to take patients' symptoms, their presentation, and findings from endoscopy and reflux monitoring into account. So what is the role of endoscopy? I think this is something that we don't often talk about much when in extraesophageal reflux or LPR. But if you look back in the 2000s, there is some smaller studies, but data that shows the patients that are being evaluated for LPR on endoscopy, about 20% will have erosive esophagitis, Barrett's esophagus, maybe a hiatal hernia. So that's not insignificant. It's pretty similar to our GERD population. And more recently, we did this study. Amanda Krause is a fellow who's really diving into this work and had 300 patients. And of these that were being evaluated for LPR, 42% had erosive esophagitis or Barrett's or peptic stricture. What was very interesting is the patients that only had the laryngeal symptoms, so in the blue, were more likely to have Barrett's or LAC or D esophagitis compared to patients that had both the esophageal and laryngeal symptoms in the salmon color. Another thing that we don't have clarity on is that we do often find inlet patches on endoscopy. And this is a large meta-analysis, almost 1 million patients. The pooled prevalence of an inlet patch is 3%, so not insignificant across the board of all patients getting endoscopy. And interestingly, when they looked at symptoms, there were high odds ratios for throat symptoms, on the order of 3 to 5, throat discomfort, globus. It's still a controversial topic. Should we be ablating these when we find them? How does it tie into mechanism and pathophysiology? But, there's something there. So I'd say upper endoscopy, we don't have high quality evidence, but there is some data to suggest that there is a reasonable diagnostic yield, probably in patients that have laryngeal symptoms with or without the typical esophageal symptoms. And then also if we find an inlet patch or see a hiatal hernia, it gives us some information about the mechanism of their symptoms. Generally, our reference standard is reflux monitoring to evaluate for extraesophageal reflux, and this comes into play when you have a patient with isolated throat symptoms or your patient with GERD esophageal symptoms and laryngeal symptoms that hasn't responded to PPI therapy. And some do also recommend doing that endoscopy before reflux monitoring. The controversy or question is which reflux monitoring system should we use? And I don't think there's a right answer that we know of yet. So we've heard a lot about wireless monitoring and catheter-based pH impedance, and they each have distinct advantages and disadvantages. So in terms of pH impedance, I'll focus on the hemi or the hypopharyngeal esophageal probe because this is what the experts that use pH impedance would recommend for extraesophageal reflux. It has that proximal pH sensor at the hypopharynx and also the distal esophageal pH sensor. And there is actually, normative data. There is systematic review of 7 studies, and they've published the 95th percentile thresholds. Now, some challenges are that one of the normative data here is that a hypopharyngeal reflux episode of 1 is normal. So if you have more than 1 episode, is this considered abnormal? Are we going to risk continuing to overdiagnose extra-esophageal reflux if we use these types of thresholds? And we don't really fully have metrics to diagnose abnormality, but we heard from Radu today that proximal reflux, may have some value in diagnosis. So I think we need to better understand what are those thresholds if we can apply this technology. There was a study done that looked at patients that had pH impedance done, and of those that had normal acid exposure, 9 actually had abnormal impedance metrics, and they concluded that the incremental diagnostic yield using pH impedance is 18%. So again, not trivial. Now, on the other hand, wireless pH, the data here is from GERD, not from a LPR population, but we know that acid exposure varies from day to day, and the story's got to be the same in our extra-esophageal reflux population. So the more days that we test, the more days that we find normal, the higher likelihood that our patients don't need acid suppression, and it can guide our therapy. So proponents of wireless pH monitoring will say that the majority of refluxate is acidic in the distal esophagus, so why not stick to prolonged wireless monitoring if it's available? So we don't have the answers, but this is some data that was presented by Amanda Krause at DDW again. 263 patients that underwent reflux monitoring. They were being evaluated for LPR. And this was retrospective, and there's selection bias in terms of why certain patients got the reflux testing. But overall, wireless pH monitoring had a higher diagnostic yield of abnormal acid exposure than any of the pH impedance modalities. You might say, okay, is this a false positive, or are we picking up too much acid exposure? And it was interesting. There were 9 patients that had both pH impedance and wireless done off PPI therapy. And these are small numbers, but if we hone into the 4 on the bottom, so there were 4 that had abnormal wireless, and all of those had at least 2 or more days of an elevated acid exposure per our thresholds. And if you look at the pH impedance, 3 out of the 4 did not meet criteria for pathologic disease. Now, again, we've heard today about how, it depends on what system you're using, which thresholds really are abnormal, but this just raises questions that we don't have answers yet, and I'm not sure which modality we really should be using in this population. So lots of questions with ambulatory reflux monitoring. I'll briefly touch on oropharyngeal pH monitoring. When this first came out, there was a lot of excitement that this might be the diagnostic test for LPR. So it's office-based, pH sensor that sits in the oropharynx. And our group and many others looked at this, and generally across the board, there was a high risk of artifactual pH drops and high false positive rates. So really across the board now, oropharyngeal pH monitoring is not considered to be a diagnostic tool for extraesophageal reflux. How about laryngoscopy? Any patient that goes to a laryngologist or ENT's office with throat symptoms will get a laryngoscopy. This is an interesting study by Mike Vasey and colleagues. They looked at, I think, about 40 asymptomatic patients that underwent a flexible laryngoscopy, and 93% of them had some abnormal sign of tissue irritation. So, laryngoscopy is not specific for LPR. Peter Belafsky and their group has developed the reflux finding score to objectively score findings on laryngoscopy. But if you give the same video to 3 different laryngologists, they will score it very differently. So the inter-rater reliability is poor. And Peter Belafsky himself will say the findings that you see on laryngoscopy are just signs of irritation. They are not specific for actually acid reflux. But with that said, I do send all of my patients to get a laryngoscopy because oftentimes our ENTs will detect a mass on the vocal cords or aparesis or something that needs to be treated by the ENT or the speech-language pathologist, but it's not a diagnostic tool for LPR. High-resolution manometry. So while it's not a diagnostic tool for GERD, there's a lot of information that we can gather. We've heard about it tremendously at Ascona. This was a abstract that was presented at the plenary session at DDW by Walter Chan's group, and they identified that patients that had an intact contractile augmentation to the multiple rapid swallow were less likely to have proximal reflux episodes, and we've been hearing today about the potential value of proximal reflux. So maybe having these types of mechanisms may be protective against developing symptomatic LPR. But what I really want to focus on with the rest of this time is 20% of our population has throat symptoms. It's not realistic to expect that this prevalent population is going to undergo reflux monitoring and endoscopy, right? So can we do a better job earlier on when they come to their primary care doctor or the dentist or our ENT colleagues? Is there a way that we can stratify who needs to get testing, who needs to get treatment? This is a question that we've been really interested in, and this was a study that we did with Walter Chan's group and the Colorado group. And we had hundreds of patients that had physiologic data that had been evaluated for LPR, and we put their data into an unsupervised model and wanted to see what the model would yield. And the patients actually ended up clustering into 5 very distinct groups. And I won't go into all the details, but for instance, if you look at the red group here, this was a population that very much had a hiatal hernia, reflux episodes. They looked like our typical GERD population. But then if you look at the green, these patients presented with globus. They had no physiologic evidence of reflux. They are probably a hypersensitive or other etiology patient population. But this is all very mechanistic and interesting from a research aspect, but not a clinically practical model. Mike Vasey's group and the Vanderbilt group, they created the Hasbier score a number of years ago to determine a model that is clinically practical. And what they identified is that if you have a low Hasbier score, you probably have a low likelihood of reflux, and you can start with pH testing off acid suppression. And on the other hand, if you have a high score, then you can start with testing on acid suppression, and that would be pH impedance. And this was validated in an external cohort. But this also got us thinking, well, can we develop a model, again, earlier on in the process to determine who doesn't need to get testing at all? And so this was presented at DDW, is the cough reflux score. And here, patients get points if they have cough, if they're obese or overweight, if they have a hiatal hernia, regurgitation, and male sex. And on the other hand, if they have globus, that's actually a negative predictor. And what we found is if the patients that had a very low score were very unlikely to have LPR, and we suspect they don't need to get further testing, and they don't need GERD treatment. They can probably bypass that. And on the other hand, if you have a very high score, then you don't need to get testing either, and perhaps we can go down a GERD treatment algorithm. So then that leaves about a third of the population that would benefit from testing. And this is right now being externally validated and does seem to be performing well. So hopefully we'll be hearing more about these types of scores. And then biomarkers. So reflux has a very unique profile in terms of pepsin, bile acids, microbiome. And if reflux is reaching the oropharynx, then there's potential to measure these biomarkers in the saliva. And there's been interest in salivary pepsin for a number of years, more recently with the PEP test, the lateral flow device that has monoclonal antibodies to human pepsin. So Daniel Sifrim's group has studied this extensively, and they initially published this study very promising that having a cutoff of 210 of salivary pepsin was 96% specific to diagnose GERD. And then in a validation study, they found that they were not able to reproduce these findings and were having very high levels on the PEP test. And I remember we had conversations about this also, and whether it was a lot issue, but the technology at that time they concluded was not ready for clinical application. Since then, we also have been looking at pepsin, and in this study, there's a group that doesn't have GERD and a group that very clearly has GERD, and the concentrations are significantly different between the populations, and the receiver operating characteristics that we found were very similar to Daniel Sifrim's initial study. And here, we're looking at the lower cutoff of 25 being 86% sensitive, but when we look at higher thresholds, 100 or 210, they're very highly specific as well. And this is just interesting because we talk about acid varying from day to day. So this was a small study that we did where patients that got 96-hour wireless pH also obtained pepsin in the morning, after meals, and at bedtime. And we saw this beautiful variation just like we see in acid with the pepsin. In general, the AM fasting pepsins tended to be the most reliable. So if this is something we move forward with, that might be the most reliable protocol. And a recent meta-analysis has concluded that there's moderate diagnostic value for LPR or GERD, and this was based on 16 articles. There's not as much work that's been done in bile acids, but there are some labs that are actively looking at it right now. And there is a method to use mass spec and separate out conjugated and unconjugated bile acids in the saliva. So this is just some pilot data, but interesting. So these are patients that were undergoing reflux monitoring. There are controls, symptomatic patients that didn't meet criteria for GERD, and then the purple is laryngeal symptoms that actually did have GERD, and they had a significantly higher concentration of bile acids in their saliva. And this regression plot may be hard to see, but the purple dots in the upper right-hand corner are the ones that had elevated bile acids in the saliva and also had an elevated acid exposure. So I think we'll be hearing more about these types of biomarkers in the future. And with the last couple minutes, I really wanted to focus on the brain-larynx interaction. We've been touching on this throughout this conference. And this is something that I think we don't talk about enough, but is incredibly important in this patient population. We've looked at this, Harry Chen, Prakash Gwali, that have found repeatedly in different cohorts that patients with throat symptoms have high hypervigilance and anxiety, whether they actually have objective reflux or not. And it's probably highlighting that these cognitive affective processes play an important role, and it's something that we need to assess and target. Recently, we worked with the Northwestern group and adapted the EHAS to develop the laryngeal hypervigilance and anxiety scale. So maybe this is a tool that we can use clinically to measure these constructs in our patients. But I think this goes beyond just hypervigilance and anxiety, and this is something that I've been learning working with my speech-language pathologist and ENTs, that whether it's reflux or whether it's laryngitis, even if that's treated, patients develop these behavioral processes in their larynx that cannot be extinguished with PPI alone. Some patients become hyperresponsive, so that's cough and throat clearing, and others develop a biomechanical dysfunction of their vocal cords, and that leads to hoarseness. So unless we get the speech-language pathologist involved, we can't effectively treat that as gastroenterologists. So I just wanted to put that out there as, I think something that's an area ripe for investigation. And what we really need is multidisciplinary collaboration. And this is an editorial that I had the honor to write with David Katzka a few years ago. And he had this very ingenious idea to liken LPR to King Sisyphus's journey, where King Sisyphus is pushing that heavy boulder up the hill. The ENTs are saying, this is LPR, go see GI. And the boulder gets to the top of the hill, and the GI says, nope, you need to go back to your ENT. This is not reflux, and the boulder rolls back down. And I think we really need to start working together so that the boulder can reach the top, and we can have some answers for our patients. So in summary, diagnostic approaches in extra-esophageal reflux, this should not be diagnosed based on symptoms alone or response to PPI. The current reference standard is ambulatory reflux monitoring, and there are many other diagnostic tools that might be complementary to reflux monitoring. But I think more importantly, there are several knowledge gaps that we really need to dive into. And what's the role of endoscopy? Several questions about ambulatory reflux monitoring and whether these non-invasive screening methods can be used in clinical practice. And my last slide is that where I think our paradigm is going is, fortunately, we are moving away from those empiric care approaches. So developing these personalized risk prediction stratification methods to understand what's the probability of GERD, what's the probability of a behavioral laryngeal interaction, and then working together so that we understand the mechanism and then we can guide therapy in an integrative fashion. So thank you very much.
Thank you very much, Rena, for your fantastic talk and keeping in time. The session is 3 minutes late, but probably we have time for 2 questions, isn't it? Yeah? Okay. So. Yeah.
Hello, Yuval from Israel. Thank you for your talk. Taking all of this into account and the to which of your patients, if to any patient, would you refer to a surgical or endoscopic procedure just for the extra-esophageal GERD?
Yeah, and the best practice advisory that was published just last month does a really nice job of outlining this too. So for me, and my surgeons will say this too, the ones that I work with, is these are the toughest patients. You know, the reflux surgery goes technically very well, but oftentimes the symptoms don't respond, the extra-esophageal symptoms. So for me, it's generally the patient that has severe objective evidence of GERD, has been refractory to medical management in conjunction with the speech-language pathology, and they have a very clear understanding of the expectations afterwards.
Okay. Sarat?
Thank you, Rena. The inlet patch is a particularly important topic and underestimated. Do you agree that about half of the inlet patch actually secrete acid? And if somehow yes, is there any study showing that PPIs are effective inhibiting the inlet patch-related acid secretion? Thank you.
Yeah, I think this is a very good question, and I've seen mixed data, small studies. Some suggest that it's not actively secreting acid, and some have suggested that if you do pH monitoring in patients that have the inlet patch, that perhaps, especially with pH impedance, that perhaps that acid reflux is initially proximal and then migrating distal. So I think it's mixed. I don't have the answer to that. But in our practice, what we have done is if patients have been refractory to treatment and they have globus and an inlet patch, we'll attempt ablation, and 50-50 will respond. Yeah. Oh, PPI therapy. I have not used PPI for inlet patch itself. I'd be really curious to hear what others do. Yeah.
Peter, last question.
Well, it's not a question, but the answer to that, if you biopsy it and you see parietal cells, it is secreting acid. And if it does have parietal cells, it will respond to a PPI. But you have to double dose it because it's got to be a 24-hour thing.
Okay. So
fantastic. Thank you very much.
Thank you very much, Rena.